Hello! Today, let's talk about how we doctors make the U.S. healthcare cost problem worse. For a quick rundown on what the cost problem is, I recommend John Green of Vlog Brothers. John has been able to boil down the whole problem into two 7-minute videos. The first is from 2013 called Why Are American Healthcare Costs So High? And the second one is from this year, 2017, called Why Can't America Have a Grown-Up Healthcare Conversation? I'll put the links in the doobly-doo sidebar. John was perfectly right that cost is the main problem with healthcare, and he was right that healthcare costs are the biggest single drain on our economy. Healthcare costs are cutting into corporate profits, throwing a wrench into state budgets, and affecting our global competitiveness. Now, what John didn't show you was how this affected your own paycheck, as shown by this graph. Did you get that? Wait, I'm going to slow down and walk you through this graph. This was a study by the Rand Corporation, a respected think tank. It looked at what your employer paid for your work between 1999 and 2009, and it shows that you got a 30% raise over those 10 years, the top of the graph. Your monthly total for 1999 was $63.50, and it went to $82.60 in 2009. But hold on, the Rand study showed that most of your raise went toward paying for health premiums, the red section. The yellow section shows inflation, so that the real amount in your paycheck in 1999 dollars, the blue section, stayed flat. So even though you were 30% more productive, your take-home pay didn't make you feel any richer. No wonder you're angry about healthcare costs, and no wonder the 2016 election went the way it did to the candidate who promised to fix the system and bring down premiums. John did a great job explaining all the reasons that our healthcare system costs are bananas, to use his technical term. For one, he talked about inelastic demand. Now, usually, if the price of something, like a refrigerator, goes up, the demand goes down. But as John said, in the middle of your heart attack, you are not going to shop around for the best bargain. You will get the critical care and pay the bill later. Or to look at it the opposite way, if the doctor offered buy one, get one free, would you get 2 colonoscopies? So supply and demand doesn't work the usual way in healthcare. But John didn't talk about two other important economic quirks in healthcare. First is provider-induced demand. There's an old medical joke about what level of vision to remove eye cataracts. If there is one eye doctor in town, it's 20/100. If 2 doctors in town, it's 20/80. And if 3 doctors in town, it's 20/60. In other words, doctors have a huge influence on tests, medications, and surgeries. And who wants to argue with their doctor? But this results in the other quirk, which is what economists call diminishing marginal benefit. Usually, the more you spend, the more you get, like refrigerators or computer memory. But in healthcare, it's different. Let's begin at the left side of this graph, starting with basic health spending like immunizations, public sanitation, and basic health screening checkups. Moving up the line to the right, the next dollars are spent on routine treatments like antibiotics for pneumonia, chemo for treatable cancers, and kidney dialysis. But as we spend more yet, we get into iffy treatments like high-risk surgery for older patients or futile ICU care for dying patients. For each additional dollar spent, we are getting less and less additional value, what economists call the flat of the curve. Then, as we move even further to the right, we get into wasteful procedures of no benefit, and finally, on the extreme right of the graph, we start actually doing more harm than good, with over-treating people. It will be no surprise to John that the U.S. is on the flat of the curve and often spills over into the more harm than good zone. Some examples for millennials are expensive antibiotics for viral head and chest colds, or unnecessary skull x-rays in the emergency room. Examples for baby boomers are PSA over-testing and annual CAT scans for smokers. Another example for geriatrics, my specialty, is the so-called memory drugs for Alzheimer's disease, which only give a 3-point improvement on a 70-point scale. Enough to satisfy the FDA, but makes no practical difference that I could ever see. So that's why I am saying that doctors make the healthcare cost problem worse by our uncritical habits of over-testing and over-treatment. So what can doctors do, and what should patients and policymakers do? My answer is cost-benefit analysis. Some experts criticize this technique as comparing apples and oranges, but if a pound of oranges costs 100 times as much as a pound of apples, I still think this information can be a starting point for making policy decisions about what medical treatments aren't worth the cost. For example, an appendectomy costs an average of $6,000. Now, appendicitis affects most commonly teenagers and without treatment is 70 to 90% fatal. So, $6,000 buys 60 years of normal life, thus $100 per quality life year saved. At the opposite extreme, giving cholesterol medication to patients who never had prior heart attacks or strokes takes 80 people treated for 5 years just to prevent one heart attack or stroke, with say 50% fatality, thus costing the equivalent of $1 million per life year saved. Not exactly a bargain. Please come back to my follow-up YouTube to look at a way that one state used cost-benefit analysis 20 years ago to set limits on spending and head off a healthcare cost crisis. Could this help us with fixing our health system in 2017? I promise the answer in the next post. It isn't as long as this one. Trust me, I'm a doctor.